Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. How are you?
I'm good. It's a weeknight, and we're joined by a special guest who didn't want to do it over Zoom. Wanted to come over and hang out.
That's what a bromance looks like. I love it.
Yeah. Just a couple of guys drinking some Bordeaux, hanging out with Chuck.
Some Bordeaux. Wow.
I have to say
Nice.
it's probably a first in terms of drinking wine while on the air, but it's kind of like Make Me Smart. They have their Friday afternoons on tap, and we're joining in.
Absolutely. It's perfectly appropriate. Well, I'll let you know if you get out of hand. I think it's a great idea.
Well, absolutely. Let's introduce our guest. We are joined by Dr. Marschall Berkes, the chief of the Orthopedic Trauma Service here at WashU in St. Louis.
Yeah. Welcome, Marshall.
Well, thank you guys for having me. I'm not sure what this is going to look like, and I apologize in advance for offending your viewership, but hopefully we can talk about some fun things and learn from each other. So that'll be great.
Yeah, I think you're the first of this category of guest that is not in the hand world, but you are in the trauma world, and I think you certainly have things you can teach us.
Well, I don't know if I could teach you anything, but I think we all have experience, and that's the best teacher, right? So I'm looking forward to going through this.
Love it. Chris.
So Marshall and I go pretty far back. We're about to celebrate our 10-year residency graduation anniversary, which for you, Chuck, was probably 30 years ago. But so we did our training together in New York City in orthopedics, and then Marshall did the great thing and helped serve our country and was stationed in Germany as part of the United States Air Force.
That's incredible. How did I not know you guys were residency mates?
You knew, Chuck.
I
Come
did? That's what happens when you get older. You forget what you knew, and everything seems fresh.
That's the beauty of it, isn't it? But Marshall's been here at WashU since finishing his military career and has risen to the rank of chief of the trauma service and is a trusted colleague and essentially the go-to person, I think, for many of us for our orthopedic trauma needs.
Yeah, well said. Well said. I feel luckier than ever to have him on the show.
I don't want to pump him up too much, but he's won pretty much every teaching award out there at the university for our department, many of which you have also won, Chuck. So he's here to give his perspective on things, and I have an interesting case I wanted to discuss.
Let's go for
it. So there was somebody who I treated early on in practice who had a humeral shaft treated with a plate and screw construct by an orthopedic trauma surgeon here, who subsequently developed a radial nerve palsy. And I actually went in and exposed the nerve and did a neurolysis, and she did incredibly well to the point where this is one of the videos you show at a meeting. Like they do so well from just the neurolysis.
Nice. Like so in clinic, it's like, hey, hold on, let me get a video.
Let me get a video. Right. My awkward one-handed iPhone video while I'm examining. We don't have the resources for anything better than that so far. So yeah, she's doing really well. I see her back. I see her back for a couple of years, and I tell her to follow up as needed because she's doing so well. And then she comes back recently. So fast forward kind of 5 years later, has lost a lot of weight after a gastric bypass surgery. And now her radial nerve is starting to irritate her again. I'm thinking maybe this is something more like tennis elbow. She's just having pain, doesn't have a frank radial nerve palsy. Put her through the whole workup. I'm like, all right, maybe it's just radial tunnel. But as part of the workup, she gets an updated nerve study showing the nerve is working reasonably well, but the ultrasound shows the nerve just kind of strumming back and forth over the plate. And I was surprised by this. I told her I wasn't sure what to do about it. I mean, have you seen anything like that years down the line?
Well, first of all, I would be curious to see what an ultrasound of any humerus with a plate and screw looks like with a radial nerve in relationship to it, right? I mean, you're looking at the one that, okay, they're symptomatic, but similar to getting ultrasounds on asymptomatic shoulders that have surprise rotator cuff tears, like I'm not sure how you interpret that, but given the clinical context and symptoms, makes you think, I suppose. Have I seen that before? No, maybe it's seen me, however. I mean, you're a smart, observant guy, and I'm less so. So I don't know. I mean, this was a posterior approach, posterior plate situation.
Posterior plates, some interfragmentary screws. But
okay.
So
have you run across anything like that in the past in your practice?
No, I have not. But I did take out some hardware today. I was thinking of Marshall and our being our guest tonight. I took out some hardware that was placed overseas 14 years ago, a
Oh, God.
forearm plate. That was super fun and made me want to be a trauma surgeon. Sounds like that's your strategy here, Dr. D. You gonna go take that plate out and take care of the nerve?
So yeah, we talked about the options, and said trauma surgeon has since departed WashU, and so here I am with taking out large frag screws. I told our fantastic fellow Adam Mosa, who's plastics trains, that these are probably the biggest plate screws he's ever going to handle in his career. But he handled it with aplomb and neuralized the nerve, but it was intraoperatively. It was really stuck down to the humerus, and then on the lateral side, and then posteriorly, as expected, it adheres to the plate. There was a little mobility there, but I was surprised by as the nerve came around the distal third of the humerus on the lateral side, in order to neuralize that off, I've never neuralized the nerve by preserving a cup of periosteum. So that was a challenging part of the dissection. It's always interesting when you're working around the radial nerve with a 15 blade, but I figured I would leave a cup of tissue with the nerve, and that was the best quality tissue.
I mean, that's sort of, the essence of informed consent, and like, hey, how are we going to make you worse potentially? And so I think that's a pretty deep conversation that you need to have with a patient with a eyes wide open type approach, because you're really going to regret having potentially permanent deficits. Not that would happen with you, of course, but it could happen.
It could happen. I mean, I have the spiel down to pretty routine phrase in terms of the chances of me making it worse are pretty low. Then you knock on wood, but I tell them it's not zero. So it's something that we both need to acknowledge.
So how far out is this patient now from their last intervention?
Enough where I can't really say. Not enough where I can divulge.
Understood.
But post-op exam, initial post-op evaluation have been good. So I think we're through the woods on that part, but it's just a question of how much endurance.
Symptom resolution, right? I mean,
exactly.
That's I think you would know pretty quickly
right.
in this scenario, whether it's like, hey, first appointment, do you feel better or not? So we'll keep his fingers crossed.
I thought she was
intended.
Exactly.
I thought she was all better when I discharged her.
I don't know what nerve does the crossing the fingers.
So I have two comments, as I often do. The first is, Marshall, I know it must catch you by surprise that Chris wanted to talk about a nerve case. I don't know how your wine drinking parties usually go, but I'm sure there's nerve discussion involved. So that's point number one.
That's why we drink the wine, Chuck.
To get through it. I understand.
Yeah.
Maybe I should be drinking wine at these little podcast sessions.
Yeah.
The second thing is, I thought that was an interesting point, Chris. I have to say it's not common, but sometimes when I do perform a neurolysis, I do bring periosteum or adjacent soft tissue, trying to prevent any type of 360-degree situation with the nerve being compressed, but I don't mind taking some adjacent tissue if I feel like it'd be detrimental to try to tease it off.
Oh yeah, I absolutely believe in taking adjacent tissue, especially in this setting. Of course, the nerve is functioning pretty well, both clinically and on electrodiagnostic studies. So, I'm not going to disrupt it more than I have to. I've never had to take essentially an entire, 3 centimeter piece of periosteum with it. So.
Yeah, super interesting. Maybe we should thank our sponsors for this opportunity to talk about wine and nerves.
With Dr. Berkes.
With Dr.
So
Berkes.
the upper hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand.
Never thought you'd hear people read copy.
That
podcast.
was magical.
Inspiring.
I think I'm gonna look up practicelink.com myself.
There you go. There you go. Yeah.
I'm not really excited about your doing any type of job search, Dr. Berkes.
The executive vice chair hat goes on now.
Yes. So can I share a different case with you, Dr. Berkes, just for maybe to talk in general principle, but also perhaps some details. I have a 23-year-old motocross rider who is highly competitive, and he flew off and has a mid-shaft clavicle fracture with about 1.5 centimeters of overlap and with, shortening. The skin is not threatened, but I'd just love to know, throw in a softball. Talk to me about clavicle fractures. There's a lot of hand surgeons out there.
Neurostatus, Dr. Goldfarb?
I'm not discussing it.
So, and he comes to you like in the office a couple days later or whatever the case is.
I love cold trauma. Yes, this is 4 days out.
No, I mean, this is good to know, right? Because I think a lot of the patients that we see on the trauma service they're treating, they're coming to the ER and maybe they're banged up with a whole bunch of other things. And amongst the laundry list, maybe, sure, they have a clavicle fracture. And so one thing to consider, if you're looking at x-rays, like let's just start there, and then we can talk about what the patient is experiencing, i.e. history. But, a lot of these x-rays are taken with them supine on a stretcher. And so that first radiographic evaluation, it's a snapshot in time, right? So maybe it is wildly displaced, maybe it isn't. It's information nonetheless. So I think when they come and see you in the office, that's really useful to kind of understand what's happened over time vis-a-vis the stability of the fracture. Because I think a lot of the time what we see is these patients get up and they start walking around, and then, lo and behold, they get interval displacement. Now, is that going to change your decision making? Maybe it does, maybe it doesn't. But it might change the patient's perception of, hey, this looks kind of crazy. Like I got this spike of bone sticking out right near my skin, and I don't like that. Saw a patient just like that this morning. So that's one thing to consider. Then we start getting into talking to the patient. Okay, like this guy sounds very active, young, healthy, high demand. So they're probably going to
sorry to interrupt. Wants to get back on the bike ASAP.
Sure. This isn't cancer, right? Like nobody has to have surgery. And sure, there was a lot of excitement, and still is, I think, in terms of operating on clavicles, because surprise, most of them do very well. And so it's a compelling surgery to perform, because I think if done well, patients do really well. Do they need surgery though? No, they don't. It's an option, it's a choice, right? So for me, thinking about indications, it begins and ends with really what the patient wants to do. And then you kind of draw in elements of how displaced is it? What do you do for a living? Do you need to get back to work? Do you need to get back to doing knucklehead things and riding a motorbike again? Okay.
Or riding the motorbike is work.
They're not mutually exclusive. So yeah, this is all part of the conversation. And I think over the course of whatever it is, 5-10 minutes that you're talking to the patient, you get a pretty good sense of what they want to do. And then considering, what it is they need to be doing. Like if grandma just needs to turn up the oxygen from 4 to 6 liters, probably doesn't need early aggressive overhead motion. But I think, this sounds like a case where I would be more than willing to offer open reduction, internal fixation, and then we can talk about, how you do that, whatever. But I think it does get patients back to better function quicker, and I would let them essentially pursue whatever it is that they want to do if that's their rationale for getting this done, right? I wouldn't operate and then say, oh, you can't go back to work for 3 months. Be like, why the heck did I have a surgery then? So
it sounds like you're like a give them the menu kind of surgeon, more than anything else.
Yeah, and some patients that are like, oh, I don't need surgery, and I can just have it repaired later down the road if it doesn't heal. Like that's, some people are totally fine with that. So I think you just let the patient kind of choose what they want to do with the best information we have.
Yeah,
I just wanted to throw out a couple of quick rapid fire patient characteristic things, and tell me whether you think that it increases or decreases your likelihood to offer surgery.
Okay.
You meet them in the ER for an isolated injury versus you meet them in the office 4 to 7 days later.
I don't think that makes too much of a difference. Probably if you're talking about meeting for the first time, like I said, there's been some time for potentially this to displace, and also they're seeking you out for whatever treatment. Maybe it's not surgery, they just want whatever, but yeah, I don't know that in of itself is a major determining factor, but yeah, potentially a little bit later, they may be having gone through a couple of days of misery and they're like, oh God, this is painful. I hate this. Like, do something. So maybe a little bit more on the couple of days later end of the spectrum, but it doesn't change for me. It's really up to them.
Assuming similar desires to return to work in terms of type of work they do and time frame, 25 years old versus 45 years old.
It doesn't make a difference to me.
Chuck, any rapid fire questions for Marshall?
Yeah, some rapid fire. I guess it never surprises me when Chris talks about nerve, and I don't want to lump you in with every other orthopedic trauma surgeon, but I guess I shouldn't be surprised you started with the X-ray discussion. I do have a little bit. I do have a question. Do you consider, and this is a hand surgeon weenie question, do you consider aesthetics, like the appearance of the shortened clavicle, does that matter? I don't think it matters functionally. Do you hear that? Do you deal with that?
Well, I think in a related sense, there is some data that maybe it does matter. And if you're talking about like shoulder ptosis, where the medial extent is displaced cranially, but really it's the lateral extent that's drooping down under the weight of the shoulder girdle and the limb. So, and with the shortening, McKee's Canadian randomized controlled trial, they said, oh, their dash scores with repetitive motion was worse. Now, am I going to hang my hat on saying, well, sir, we can get your dash score such and such better if we repair this thing? I don't know, but I think it lends itself to the alteration of the length tension relationship of your rotator cuff and shoulder musculature. And that's not going to get better. A patient comes in and they're like, this looks kind of weird. They're like, well, if we're going to treat without surgery, it's going to look like that basically forever because it's going to heal in that position. And that's fine. Again, if you are okay with that. So I think making that clear to the patient is important.
So thank you. Perfect. What, talk to us very briefly, and this could be a rabbit hole, it's not intended to be, about multi-trauma. So if you have an ipsilateral or contralateral femur fracture or forearm fracture, do those really ramp up your, I guess, pushing at least a little bit for clavicle fixation?
Yeah, for me it does. I mean, I think you try and stack everything in their favor in terms of being able to utilize whatever it is that they have that can be as functional as possible as soon as possible. And this is something that patients feel pretty good pretty quickly after this operation compared to some other things, which that's not the case. So I think it does afford them to maybe use their limb a little bit more effectively if they have lower extremity trauma. I guess how you define polytrauma is a little bit of a question. And then there's always, if you want to go rabbit hole mode, people with chest wall injuries, there's some question about, hey, if they have multiple ribs, does fixing the clavicle help with kind of chest wall architecture, and does that provide any additional benefit? That's not entirely clear or borne out, but that is thrown out there as a rationale for surgical treatment.
What about a scapular fracture?
Yeah, I think that's reasonable, particularly when it's a displaced scapular neck or whatever the fracture pattern may be, in conjunction with a clavicle. People have different philosophies and treatments for that, but I think there's quite a bit of alignment on, okay, if we start out the clavicle, then maybe there's an indirect reduction of the scapula and that doesn't need to be treated. I think they have to be considered independently, but for sure the combination of the two probably just speak to the level of violence and displacement and potential benefit for early stability.
Or the so-called floating shoulder. Yes. Okay. And then
wow.
I have,
I had a follow-up question, if that's okay, unless you have one.
No, go ahead. I got one more, but you go.
Well, so we do have a lot of hand therapists, physical therapists, OTs that listen. And you mentioned, in terms of allowing somebody to go onto an expected malunion, which we see a lot, for example, with the distal radius fracture in our population. I've learned what to tell them about. because I've heard enough about what I didn't tell them about in follow-up. So the appearance is one thing, so you touched on that.
Yeah.
Are there functional things that perhaps you've noticed over time when you've treated somebody without surgery? Is it endurance? Are there particular, types of shoulder or glenohumeral motion that they lack in terms of activities? Or what are the things that if you're going to treat somebody non-operatively, our listeners should make sure to talk to our patient?
Yeah, I mean, I do mention kind of that repetitive motion thing just in strength, just because that's really the only thing that I've read that says that, yes, this may actually be true. But I haven't had, and my experience is not vast, so take it with a grain of salt, but I haven't had tons of clavicle malunions coming in and complaining of, massive functional deficits. I think it's more the non-union patients that you end up seeing, at least in my case. So I don't have an abundance of wealth with answering that question directly.
Chris, do you take care of clavicle fractures?
Also, I fix them all, so I don't.
Aha, pearl of wisdom there. I don't, unless I guess if I'm in, I guess the only situation is if I have a clavicle osteotomy I'm dealing with to get access to the plexus. But I have not primarily fixed a clavicle fracture since starting practice. I know a couple of our hand partners, may have some flirtations with such fixation, particularly on the call.
Yeah, I fix clavicle fractures. I don't go seeking them out, but I'm happy to do it. They're fun surgeries, and we should talk a little technical. So, Marshall, sometimes Chris, especially sometimes even I get consulted to help with exposures. So, for example, sorry, I can't. I'm cracking myself up. So, for example, the peroneal nerve, when we're worried about the posterolateral corner of the knee, or the sciatic nerve with the hamstring avulsion. Have you ever consulted Chris for the supraclavicular nerves to identify them and keep them safe?
Short answer, no. I think the question you're trying to ask is, how do you handle the nerves on the exposure? There's different schools of thought. I've been involved in cases involving preserving all the nerves. I've also heard, this is all anecdotal, that patients have more kind of painful nerve type symptoms potentially as a consequence of that, because of then the stretching and the irritation of the supraclavicular nerves. I've heard of people injecting the nerves and then sharply transecting them as a method to eliminate that as a possibility. I mean, obviously that is going to result in some chest wall numbness, or you can just ignore them entirely, as I do. And I have not had anyone complain to them. Maybe they're all going to Chris, I don't know, but they've not complained to me directly about that. So my personal approach and philosophy is just to basically go right through them, and haven't had anybody complain of chest wall numbness and or dysesthesias. That's not to say it hasn't happened though.
Nor do you ask.
True.
There may not be a second glass of wine for you tonight with cutting through all those nerves.
Well, no, I think that, so when you go, is it skin, and then after the skin, is it bovie down the bone, down to periosteum, or is it knife, you scalpel the whole way?
No, I mean, it's through skin with a knife, and then typically it'll be, for this electrocautery dissection to the clavicle. Yeah.
Because I think that your point of, having to dance around the nerves and then inevitably somebody stretching them a lot, it actually is better, I think, if you're going to do it, just bovie through them. Rather than protecting them, but then subjecting them to just a ton of stretch and irritation.
Yeah.
It's kind of like some people treat a neuroma by cauterizing it. So I actually don't think it's that flawed of an argument. But I guess it depends on who's handling nerves. And
sure. Right. Yeah.
Hey, Chris, before we talk technical, should we thank our sponsors?
Yes, we should. The Upper Hand is sponsored by Checkpoint Surgical, a provider of innovative solutions for peripheral nerve surgery. Checkpoint invites you to visit them at booth 605 at the ASSH annual meeting in Toronto to learn about their new products, as well as to attend their industry forum on Thursday, October 5th at 11:30.
The program, Nerve Injury Reconstruction Challenges, will be moderated by Scott Cozen, Chief of Staff at the Shriners Hospital for Children in Philadelphia and past president of the Hand Society. To learn more about this program and to register to attend, please visit nervemaster.com. Checkpoint Surgical, driving innovation in nerve surgery.
you use the checkpoint at all, Dr. Berkes?
I do not.
Okay. All right. Leave it to us. We'll handle it for you. I'm
Okay,
glad I could stay in business.
sure.
All right, so let's go back to that somewhat straightforward midshaft clavicle 23-year-old motocross rider, and you and he have had a wonderful discussion and have elected to proceed with surgical intervention. And just without getting too much in the details, but also not too superficially, just take us through how you do this. I'll ask you some questions. Positioning: is this beach chair? Is it supine? Where is your incision? Is this one plate, two plates? And if they're, help us understand why you choose which fixation.
Or a nail.
Sure.
Or nail.
So my personal preference patient is supine on just a radiolucent, kind of like a diving board type table. So not any specific beach chair or positioning things. Otherwise, I do elevate the head of the bed probably 20-30 degrees. I think it helps kind of get all the neck fat and just kind of stuff settle away rather than working down into a hole. I used to kind of put a bump under the scapula or between the scapula. I stopped doing that. I just haven't found it to be incredibly helpful or necessary. I just do a window prep and drape. I don't prep out the whole arm. Again, haven't found that necessary or a requirement. I have the C-arm, so I'll turn the bed 90 degrees and I have the C-arm come in from the head. So the two views I'll use, they'll roll back, essentially until the bottom of the C-arm hits the bed, and that's about 20-30 degrees roll back, which gives you kind of a good top-down shot, and then roll over all the way, and that'll give you a good, real AP, if you will, of the clavicle itself. So that's the general setup. The approach is nothing special, down to bone. I think the mistake I've seen is a lack of exposure and a lack of awareness of the fracture. These are always more comminuted than you think, would be my general summary statement on that. You think you're going to go in there and these two pieces are going to click in, and it's like, lag screw, neutralization plate, done, whatever. There's always multiple pieces. There's always kind of this caudal comminution that I don't personally really pursue with dissection, nor do I think is a good idea, because it's going to require quite a bit of stripping of whatever is keeping that fragment alive. So the general strategy becomes using whatever reads that I can expose on the anterior and superior aspects of the clavicle, and typically you can get enough of it reconstructed that there's maybe 270, 180 degrees of the tube back together and aligned, and then how you hold it there is a little bit of a case-by-case basis. I personally like kind of drill holes in the bone and then just like a straight point-to-point clamp to hold that, and then put a plate on the surface that the clamp is not in. So if it's on top, then I put the plate in front. If I have the clamp in front, then the plate goes on top. I personally have been trained in and really like the dual mini frag plate fixation, and that's typically like a thin 2-7 plate on the superior surface and a thicker 2-4 plate on the anterior surface. And those are just contoured. Most people have pretty reasonable bone quality, so it's not like you need tons or any locking screws. Caveat is when you start getting pretty lateral, the distal clavicle bone quality, even in young people, is not fantastic. So the last one may be a locking screw because it makes me feel better. I don't know if that's a requirement, but, and then the other pearl.
Hold on, no, Tom, you got through a lot. We got to unpack some of this first before you go to
Okay.
the last pro. Stay the last pro.
I'll stop.
So do you pre-contour your own plates, or do you use a pre-contoured plate? Do you contour on the fly? Do you let the bone do some of the work? How do you make that decision?
Yeah, I just, these are just straight plates out of whatever mini fragment set you like. And I think the ones that have longer plates are nice because, again, frequently these are more comminuted than you may appreciate just on initial review of the plane x-rays when it's shortened and malaligned. So you may have to go fairly extensile along the medial to lateral aspects of the clavicle to get this thing, I would think, sufficiently fixed. Now, what that means is part aesthetics and religion potentially, but a good working length and something you feel like is well fixed. So yeah, some of those 16, 18, 20 hole plates, and you can just cut it to whatever length you like. And then, yeah, I'll just use a plate bender, having one that allows you to bend it on the flat in addition to sort of a cranial caudal type bend is going to be necessary. So there's different commercial plate benders that are in most sets. So
I remember for that cranial caudal plate bender, I actually had one of the implant companies find one and get one made for me, and then somehow it ends up in your tray.
well,
They know where their bread is buttered.
Yeah.
I appreciate that description. I have to say, you'll be proud to learn that Zach Meyer, who you know is one of our pediatric orthopedic attendings, doing a little bit of specialty trauma work, has been using your 2-plate model and credits you in conference. And I always ask him why would he waste 2 plates when one will do the job, but he is proudly using 2 plates and states that it decreases the need to take out hardware and decreases complaints with wearing backpacks.
so I think there is something to that. Now, the other part of this is that with these plates that are so flexible, you can do some in situ, you don't have to have it contoured perfectly because it will conform to the bone, not overpower the reduction, versus a thicker pre-contoured 3-5 plate where, number one, unless you're a 70-kilogram Swiss man, it probably is not going to fit you. Okay. So that's one problem, number one. And number two, even, if it fits relatively perfectly, it is pretty bulky. And so I've taken out of the patients that I have personally operated on with this technique, I've taken out one set of plates, and I don't remember exactly how many, but way more that have been fixed elsewhere using small frag, and they come in and they want it out. That's, I think, something that goes into the rationale for doing it. But sure, 3-5 they work just fine. So I think whatever you're comfortable with and whatever works in practice that's great.
Do you have anxiety when others are drilling to place screws in the clavicle about the large vascular structures which are nearby? Because I hear so many people talking about this, and I don't think I have the appropriate amount of anxiety. Of course, I want whoever is holding the drill at the time to show appropriate care and not plunge. Do you do anything to protect those deep structures, or you just expect good surgical technique?
No, the latter. Yeah, I don't, go out of my way to do. I don't know what that would involve. Homins underneath the bone, or if the opportunity presents itself, sure, fine. But no, I'm not like super OCD about that, other than the sense that sure, like operate like you should, and there should be no issues.
So what was the last pearl you were going to share before we cut you off?
Oh, yeah, as you get lateral, at least my ability to kind of understand exactly where the end of the clavicle is, it gets tricky. So before you go ahead and plate the whole thing and start high fives all the way around, and you discover you have the end of the plate over the AC joint, or even a screw in the AC joint, it may be worthwhile to check that earlier on in the case, just because it can be tough to tell. So
I think.
Go ahead, Chuck.
I was going to say, I think that's good advice. And I will say some of the pre-contoured plates, I've struggled. I've used understanding what I'm doing, I've used the right clavicle plate on the left clavicle. And I think your point about the contouring, no matter how well meaning it is, it just doesn't work for every patient. So I think that's a really important point for those who like those plates. Just be flexible in how you approach which plate you use for which patient, and be careful on that lateral clavicle. Totally agree.
Yep.
So a couple of quick questions as we wrap up. First one is, are there any remaining indications that you see for use of anything other than a plate screw construct?
Yeah, people have experience. There's different, these flexible, let's call it nailing intramedullary fixation systems, or even something that's not as advanced, like titanium elastic nail I've seen used. I've seen technique written up. I think it was out of one of the Army hospitals using, I think it was a 6.5 can't sell a screw, essentially intramedullary, hitting it on the straight part of the clavicle, or at least that's what I assume,
Right.
based on the geometry of the screw itself, with the concept that it avoided a larger incision over the area and a plate over the area where they're carrying their rucksacks, which,
Right.
weigh in excess of 80 pounds or whatever it is. So, I think that's a rationale. I don't personally employ that. It seems like a solution to a problem that I don't currently have.
Okay, well
Yeah.
said. And then I think the last question I wanted to ask you was, what does your rehab protocol for this look like? How much are you limiting any shoulder motion, initiating shoulder motion right away? Do you have any limits on activities, weight limits, that kind of thing?
Yeah. Like most things that I take care of, I've kind of evolved over time, just because ultimately patients end up doing whatever the heck they want, and most of the time works out just fine. So there's a lot of self-protection, I feel like, just in terms of what we say, oh, don't do this,
Right.
because that's what I was taught in residency, and we're just bond in that regard. But so active, passive range of motion, no limits, straight away. Give them a sling, but I just tell them, get rid of the sling whenever you want to. You just start moving your shoulder. I don't normally prescribe physical therapy the first 3 weeks until they come back, and then we kind of figure out, hey, how you doing? How you feeling? Most of the time they're feeling pretty good and they have pretty reasonable motion. I'll offer it to them. You like to do physical therapy? I think you get a sense of which patients are pretty gung-ho on that and which ones are not so much. And then in terms of lifting, pushing, pulling, job related stuff, I'm still, if somebody said, oh, I need to go out there and start power lifting or lifting 100-pound bags or whatever, I don't know that anything before 6 weeks I'd be super enthused about that. If they said, hey, I gotta get back or else I'm gonna get fired from my job, and then I think I would be willing to make that compromise. That's a pretty rare situation, but usually this is the sort of thing where I feel like I end up trying to potentially even like slow them down a little bit, just because they're feeling so well and like want to get back out there and do something. And maybe we should. I don't really know, but I think the first 6 weeks is some reasonable limitation, just in terms of how much they're getting after it with the weight bearing. And as we mentioned earlier, like, polytrauma, it's kind of like whatever you have to do to get out of bed and mobilize, use your arm, that's fine by me. So,
so if you have to really kind of put you on the spot, if you have a high school football player who wants to get back, a running back wants to get back and play, you fixed his clavicle, you're really happy with the fixation, and you say you can't play for 6 weeks, come back in 6 weeks, I'll get an x-ray. Do you have to see healing on that x-ray to release him at 6 weeks? Or is the 6 weeks without any negative negatives on the x-ray good enough?
I suppose it was, what kind of healing are you going for, Chuck? Because I don't know how you intend to see healing with absolute stability.
Well, you told me you put soft plates on there.
On the caudal side.
Right. Yeah. Well, yeah, I think I would go more based on clinical finding, if the x-ray looked unchanged in the sense that everything's well aligned, there's no loosening of screws, patient feels well, they're dying to get back, if it's worth it to them so much that, okay, yeah, is there a risk that this may displace or whatever? Yeah, I suppose that's possible, but again, I think that's the art of the patient physician relationship, and just understanding what's important to them. So I would kind of suss it out clinically rather than radiographically in the absence of any negative findings.
Perfect. This was awesome.
Thank you for joining us, Mark.
Thanks for the softballs. If you guys want to talk about, like mangled lower extremities, it's like, I'm out.
Not so much.
I don't want to talk about that.
All right, y'all have a good night.
All right, take care. Thanks for having me.